Bismillahirrahmanirrahim. It's a big honor to be with you today to speak about a couple of cases of strabismus. I know strabismus is not that fruitful for many of us, but let's start with one of cases. This is a 20 years old guy coming with me with right exotropia and poorly moving eye after having a couple of surgeries elsewhere. One of them, it was when he was 8 years old. And the second surgery, he went with this picture to another doctor and he told them, I found nothing to operate because I found one of your muscles was cut and I can't retrieve it, so nothing to do. By examining this patient, I found right exotropia, which is not moving and no adduction at all of the right eye. It's hardly getting to the midline, so there is severe restriction of adduction of the right eye with incompetence. And on looking to the right gaze, he has unexplained alphabetical or vertical form that I couldn't explain at that time. So what I can get from checking for limited adduction after having a complicated surgery that I don't know the nature of which, so this case has incompetent squint with limited adduction, and mostly this is a lost or slipped medial rectus. So my challenge is to go to search for the medial rectus, is it there or not? If I can find the medial rectus, it's easy to retrieve it back and advance it to its original anatomical position. If I couldn't, it's my time to do transposition to allow for adduction of the eye. But when I went to surgery, I found something different. I have 4 surprises in that case when I was operating. ممكن نشغل الفيديو؟ So first I have to search for the medial rectus. Can I get it back or not? And my first surprise is the medial rectus is there, existing in a recessed position of 4 millimeters from the cornea. I dissected. There is an intact medial rectus, it's not slipped or lost. So going back to see what's happening on the other side of the lateral rectus, and I tried to explore the lateral rectus. I found a recessed lateral rectus about 12 millimeters from the limbus, so it's recessed 5 millimeters. I have more to do more recession of the lateral rectus. So let's catch what's happening there of this tissue. I don't know, is it a pseudo tendon or a true tendon? I sutured the lateral rectus and then disinserted to search back what's happening there and try to have a guide through the inferior oblique, which I found its fibers very near to the lateral rectus but a bit behind. Then I found that membrane connecting the back of the lateral rectus to the inferior oblique. My way will be easier if I could retrieve the inferior oblique to dissect to find my second surprise, which is a split inferior oblique. I found the inferior oblique is split in 2 halves. One of them is attached to the back of the lateral rectus and the other one is back in the normal place of the inferior oblique. I have to collect both halves with each other to have a complete, intact, well-dissected inferior oblique without cutting any part of the muscle itself, to find my third surprise, which is a membrane connecting the half of the inferior oblique to the back of the lateral rectus. This may explain now what is the vertical pattern that I couldn't do. The tough mission was to separate the half of the inferior oblique from the lateral rectus. This syndrome is not that usual. It's called inferior oblique inclusion syndrome, connecting the inferior oblique. And usually we have this problem when a beginner starts to do lateral rectus recession. He's scared not to have the full fibers of the lateral rectus, so he goes back with the hook to retrieve the lateral rectus. But usually it ends with a complication of having entangled fibers of inferior oblique with the lateral rectus itself. So to cut this membrane is to separate the 2 muscles from each other, have separate inferior oblique back to its position to work as an elevator and adduction as usual, and doing more recession of the rest of fibers of lateral rectus with its cutting its pseudo tendon, doing more recession. After that, we can go to our medial rectus, which was lax and originally recessed, to get resection with advancement, or we can call it augmented resection of the medial rectus to have a powerful adduction. And it's mandatory in these cases to have a powerful adducting muscle because of the long-standing exotropia may lead to fibrosis of the check ligaments and tendon capsule that not allow adduction easily. So back to do usual resection of the medial rectus, but getting it advanced to its original position, which was 5.5 millimeters from the cornea. So I finished my 3 surprises intraoperatively to have conclusion of the surgery after doing the resection of the medial rectus, but I have no idea what will happen tomorrow after having these maneuvers. And my 4th surprise came second day post-operative when I have an aligned patient. I didn't expect that good results, to start with incompetent exotropia and ending up with this well-aligned position with proper accepted adduction. My second case was another one of exotropia, but spontaneously happening with no evident cause, in that 21-year-old girl coming with this exotropia spontaneously, with no medical history, no history of trauma, or no history of any blood or systemic diseases. She was operated 8 months before coming to me, and the report was sent telling she underwent lateral rectus recession and the medial rectus resection of the left eye. But when examining after having this surgery operated elsewhere, she has left exotropia, limitation of adduction of the left eye, and limitation of depression as well. So this is a case of inferior division third nerve palsy, because she has intact elevation and intact superior division as we have good levator function. So what can I do now? I have a paretic medial rectus and affected depression because the inferior division of the third nerve is not working well, but I was happy and lucky to have this good commitance, because when I put the prism on the other eye, the eye adducts and I can get the primary position aligned if I deviated the normal healthy eye. So what I can do for this case is doing just the recession resection of the right eye to allow adduction of the left eye, but to do proper correction of the hypotropia, I can do reversed nap technique, which is transposition of the medial and the lateral recti to be on the temporal and the nasal sides of the inferior rectus to get a bit better adduction. Second day post-operative, she was much better, having improvement of the vertical position, improvement of the exotropia, having accepted outcome, but still we have limited depression of the left eye, limitation of adduction, but I can do more surgeries for this eye because attacking more than 2 muscles of the recti can lead to anterior segment ischemia, which is very devastating to the eye. So let's wait for 6 months to do my second attack, and I was happy having this picture of improvement. She's taking adaptive head posture to get rid of the ugly look of the left limited adduction. And this is my situation now. Hypertropia, limitation of adduction, and a bit exotropia, but I was lucky having good intorsion on depression, which means intact fourth nerve and superior oblique. So my plan was to do larger recession of the superior rectus and doing transposition of the superior oblique to attach it on the medial side on the insertion of medial rectus to work as an adductor. This was my patient, second day post-operative, but on long-term follow-up, now she has orthotropia in primary position, accepted adduction, and a bit much better depression of the left eye. Thank you very much.